allow me to welcome you to the next session, my favorite session on immune reconstitution. Do we have critical mass? Yes, I think we do. My name is Katja Weihnacht, and I'm one of the faculties in Alicia's rapidly growing division. And so over the past day and a half, we've heard that every tiny change that we implement has far-reaching consequences. And of course, with that, we need to look at immune reconstitution. But to really understand discernible differences, we need to do two things: look at large patient numbers and look over a long period of time. Our next speaker is Valentina Bertaina. She runs the flow cytometry laboratory and is the director of the immune monitoring program at Bambino Gesù Children's Hospital in Rome. And I think it's fair to say that she's the woman in the world right now who oversees the largest cohort of patients who had an alpha-beta CD19 depleted transplant. So what she's going to teach us today will have far-reaching consequences how we design the next perfect graft of the future. And of course, it has not been lost on you that this is a very familiar last name. So I've been thinking probably the name Bertaina constitutes a gain of function mutation in how we move the field forward. So Valentina, we are very excited for your talk.
Thank you. Good morning, everybody. It's a pleasure and an honor for me to be here today. So I want to special thank the organization of this special event and Alice for the invitation. So today I want to share with you some data regarding immune reconstitution after hematopoietic cell transplantation. So before showing you directly our results, I would like to briefly review what is already present in literature in this context. In 2014, our group showed results about how lymphoid subsets reconstitute after transplant, monitoring for 12 months a restricted cohort of 23 patients with non-malignant disease. So in 2017, also analyzed for the same time lapse, 80 patients with malignant disease, recently updated by Pietro Merli with 133 patients with a longer follow-up of 47 months. And so in 2018, moreover, the data were validated in a multicenter retrospective analysis in 13 Italian centers, comparing match-unrelated donor versus mismatch-unrelated donor and haplotransplant in patients with malignant disease. So a successful post-transplant immune reconstitution represents one of the most critical variables for a favorable clinical outcome. Recently, few biomarkers of successful post-transplant immune reconstitution have been identified, like CD4 immune recovery at day 100. And little is known about the role of these biomarkers and the kinetics of immune recovery in the Haplo setting. So the aim of our study was to analyze both lymphoid and myeloid population after TCR alpha-beta CD19 cell-depleted haploidentical transplant in pediatric patients to gain a complete insight on immune recovery. These are some characteristics of our patients. We retrospectively analyzed 126 patients between 2018 and 2020, with a median follow-up of 16 months. The variables analyzed were age, gender, conditioning regimen, TBI, primary disease, CD34 dose infused, viral activation, specifically cytomegalovirus and adenovirus activation, GVHD occurrence, and donor source. The median age was 8.2 years. This is a brief summary of the haplotransplant platform used at Bambino Gesù Children's Hospital in vivo T-cell depletion with ATG before the transplant, PTLD prophylaxis with rituximab at day -1, and then the patient did not receive any post-transplant immune suppression. Here, the median cell dose infused with the graft and the general outcome of all patients. Starting from the engraftment, 118 patients out of 126 achieve a complete neutrophil engraftment at median time of 14 days, reaching a stabilized value in the peripheral blood within 1 month following haplotransplant. we only observe a slight difference in time of engraftment, depending on TBI administration and disease type. Specific flow cytometry analysis to quantify long-term immune reconstitution demonstrated that neutrophil absolute cell number maintained the same trend from the first month up to 24 months after haplotransplant, suggesting that the entire cohort of patients rapidly normalized the total circulating number of neutrophil despite prior diagnostic history. So none of the analyzed variable seems to affect long-term neutrophil immune recovery. And also the monocytes appear in the peripheral blood at early time points, keeping the same trend up to 24 months. And specifically, we studied the different monocytic subpopulation, as you can see on the flow cytometry plot. Using CD16 and CD14, we discriminate classical monocytes, intermediate monocytes, and non-classical monocytes. And as you can see in this graph, the classical monocyte subgroup in dark blue is predominantly represented in the peripheral blood already at 1 month post-transplant, followed by the intermediate monocyte and from the non-classical monocyte. So also for the monocytes, none of the analyzed variables seems to affect long-term monocytes immune recovery. But moving on lymphoid compartment, all lymphocyte subsets achieve a normal value for age in all surviving patients with a median time to normal CD3 level of 13.5 months. CD3 T cells reach a threshold of 500 cells microliter at 6 months post alpha beta transplant. CD4 cells and CD8 cells have the same trend, but from 9 months after the transplant, CD4 cells expand much more. So alpha beta T cells becoming the predominant subpopulation already at 4 months post-transplant, and gamma delta T cells, as expected, expand rapidly after the transplant and remain stable at every time point analyzed. Here, the absolute number of alpha beta T cells, CD3 T cells, and gamma delta T cells. So, interestingly, non-malignant patients show a statistically significantly higher absolute number of circulating CD3 lymphocytes at 9 months post-transplant than patients with malignant disorders. With regard to CD8 T cells, we only observe that patients who experience viral activation, cytomegalovirus rather than adenovirus activation, have a higher absolute CD8 T cells. As already demonstrated by other group, viral activation speed up the immune reconstitution of CD8 T cells. And with regard to CD4 T cells, up to 9 months post-transplant, we observe a first wave of effector memory T cells expansion that you can see in blue, most likely derived from the few alpha beta T cells infused with the graft. And from this point, so 9 months after the transplant, a new expansion of naive T cell is observed in green. We hypothesize that these naive T cells are newly generated from the donor cell. Indeed, Enrico Velarde's group, which specifically studies thymic reconstitution, has shown in another cohort of patients how recentymic emigrants defined as CD4 positive, CD31 positive cells are already detectable in the peripheral blood as early as 3 months after the transplant. In this graph, absolute number and percentage of recentymic emigrant comparing haplotransplants versus match-unrelated donor transplant. And specifically, the thymic function was also evaluated directly by measuring signal joint track. They found that this subset were already detectable 3 months after the transplant. So this data strongly correlate with the flow cytometric measurement of recentymic emigrants and also with naive. Analyzing in detail CD4 cells, we observe that children younger than 6 years old reconstitute CD4 lymphocytes faster than older patients. And in addition, non-malignant patients have a higher absolute number of CD4 cells. This is consistent with the better thymic function of younger children. Interestingly, specific analysis of the subcompartment of CD4 positive, CD20 high, and CD127 low Treg cells revealed that these population also contribute to the total reconstitution of CD4 lymphocytes appearing in the peripheral blood at 4 months post-transplant. Moreover, we observe that younger age, non-malignant patients that do not perform TBI, and patients that infuse high dose of CD34 cells have a higher Treg absolute number. And acute GVHD incidence and adenoviral activation and cytomegaloviral activation did not impact on the kinetics of Treg immune reconstitution. So in our study, patients were also analyzed based on the capability to achieve more than 15 CD40 cells microliters at day 100 for 2 consecutive points of observation, defined as CD4 immune recovery. This biomarker has already been studied by other groups that show that early CD4 immune recovery predicts survival after hematopoietic stem cell transplantation in a variety of transplantation platforms. And they demonstrated the strong association between CD4 immune recovery and non-relapse mortality. So in our study, the cumulative incidence of CD4 immune recovery at day 100 was 68% in the whole cohort, while it increased up to 93% in children younger than 6 years old, always consistent with the better thymic function of younger patients. And in addition, patients with early neutrophil engraftment, less than 14 days, seems to have a slight advantage on CD4 immune recovery. Notably, we did not observe any correlation between acute GVHD, cytomegalovirus, noradenoviral activation, and CD4 immune recovery. So in our cohort, CD4 immune recovery did not impact non-relapse mortality. And moving back to the innate immunity, NK cells, as already know, rapidly increase during the first month, remain stable up to 6 months, and then expand after 9 months. We observe also for this subset that younger age, no TBI, and patients that infuse high dose of CD34 cells have a higher absolute NK number. And what about B cells? B cell recovery is delayed after TCR alpha-beta CD19 cell-depleted hematopoietic cell transplantation due to the ex vivo and in vivo B cell depletion. So we see this subset only starting from 6 months after the transplant. And also for this subset, younger age, no TBI, and CD34 high dose correlates with early B cell reconstitution. In conclusion, this is the largest cohort of pediatric patients, 126, given TCR alpha-beta CD19 cell-depleted hematopoietic cell transplantation longitudinally evaluated for myeloid and lymphoid immune recovery. Myeloid recovery after this setting is fast and sustained over time. Younger age, less than 6 years old, higher CD34 dose infused, and the use of TBI during the conditioning regimen were independent factors influencing adaptive and innate immune recovery. So the probability of CD4 immune recovery at day 100 was 68% in the whole cohort, while it increased up to 93% in children younger than 6 years old, consistent with the better thymic function of younger children. neither GVHD occurrence, cytomegalovirus, nor adenovirus reactivation influence CD4 immune recovery. Patient with early neutrophil engraftment seems to have a quicker CD4 immune recovery. So finally, younger age at time of transplant was the only predictive variable for of earlier CD4 immune recovery in this Haplo cohort. So thank you. First of all, I want to thank, another time, the organization. I want to thank Franco Locatelli, my professor, all the clinicians, the cell manipulation unit, all the researchers, in particular, Raffaella Sborgia from my lab. And let me say a special thanks to Alice. Since I was little, she has been my mentor. And if I am here today, it's because she always inspired me to never give up. Thank you.
Thank you, Valentina, for this absolutely wonderful talk, probably the most moving one as I look at a literature of this entire symposium. Questions, Maria Grazia.
So, Valentina, first of all, congratulations for a beautiful talk. You managed to have your sister crying by emotion, I know. So I have two questions which are related to each other, actually. So the first one is that you say that you see an expansion of the CD8 when you have reactivation of CMV and adenovirus. So I assume that this expansion of the CD8 comes from the naive CD8 that become memory. Mm-hmm. And the second question, which is related to that, I was really surprised by your statement that you say that the CD4 positive immune reconstitution is not modified by the GVHD or by the CMV reactivation. Because I assume that when you have GVHD, you get steroids and a number of other immunosuppressants, but that by definition are either lytic or suppressive on the CD4. So two questions which are related to.
Thank you for your question. So I start from the second one. Surprise only for us that the result about acute GVHD so maybe this data could be limited by the retrospectivity of the study. Most of our patients experience mild skin only grade 2 acute GVHD. So, and this resolve after a first line treatment with steroids. So maybe we have to extend the cohort, extend the number of patients to found a correlation. And can you repeat the first one?
It's about the CD8, so that you see an expansion of the CD8 when you see reactivation of CMV and adeno. And I was wondering if you look at the relative composition of CD8 naive versus memory.
I think it's memory one, but I have to check. I have to check this data, but I think memory T cells.
I just wanted to try to address Maria Grazia's question about the CD4 immune reconstitution and the graft versus host disease in two ways. One, I think that the analysis that you did was evaluating the incidence of GVHD by CD4 immune reconstitution. So for those patients who achieved the CD4 immune reconstitution, if there was any different incidence of acute graft versus host disease and non-relapse mortality, because Yapian Bolens actually did that analysis in his retrospective cohort and showed that incidence. The other point is that, obviously I cannot talk for the most recent patients, but historically, we have used much lower dose of steroids for these patients that we are used to use here. For the grade 2 skin GVHD, we never use more than 0.5 milligram per kg total of steroids, and we use much more photopheresis. So the immune reconstitution was less impacted because of that. Bravissima, Vale.
Allow me one last question. question before we move on to our next speaker. Valentina, you pointed out that the immune reconstitution for patients who with non-malignant condition was significantly superior over that of patients with malignant conditions. And now we know that at your center, most patients with malignant conditions receive a TBI-based conditioning regimen. So I think Chris is probably smiling over there and thinking that the next trial we want to look at is using Melphalan versus TBI and see whether that immune reconstitution changes. So something we could do here. You're right. So any other questions for Valentina? Then we move on to our next speaker. Our next speaker is my dear colleague and friend, Rosa Bacchetta, who is a professor in our division. Dr. Bacchetta has really devoted her entire professional life to the study of a cell we all love, regulatory T cells. They're peacemaker cells and they just promote positive associations. She's also leading first-in-human clinical trials right now where she uses gene-modified FOXP3 positive autologous cells to treat patients with IPEX. But today she's speaking about a different cell type that to me is even more enigmatic, a cell that we lovingly call the T-allo10 cell. It's a cell that promotes allogeneic tolerance while at the same time retaining anti-tumor properties. So Rosa, tell us about our trials in children and young adults with this very enigmatic cell.
Okay, thank you for the introduction and thank you very much Alice and Maria Grazia for giving me the privilege to show this preliminary data on their trial basically. So the trial is actually the addition of T-allo10 cells in post-alpha beta depleted transplant. Let's see if you see my mouse. Okay, yeah, there. Okay, so the rationale of this trial is improving the suboptimal T cell reconstitution after alpha beta depleted Haplo with the infusion of these T-allo10 cells. We actually have, we know that we have seen, I mean, very beautiful data, but we know that even before 100 days, there is a window in which the gamma delta cells are starting to decrease and the alpha beta are not yet present in sufficient number to be to give immunocompetence. And also our internal data show that only 30% of patients can achieve more than 50 CD4 positive cells per microliter by day 60. And this with, of course, negative consequences on relapse and infection. And so we wanted to challenge these numbers by the infusion of T-allo10 cells and providing better reconstitution even before day 100. What are T-allo10 cells? T-allo10 cells are CD4 positive, is a CD4 positive cell product and is derived from the donor, of course. And these cells are challenged with and primed with tolerogenic dendritic cells derived from the host, so from the patient, within a 10 days culture in the presence of IL-10. The resulting cell product is an heterogeneous population enriched of T regulatory cells type 1 and which are host specific and which are able to inhibit and to control effector T cells and therefore potentially can prevent graft versus host disease. These TR1 cells, they also have the ability to kill myeloid leukemia cells, and interestingly, the rest of the cells remain pretty much unaltered, and so they are able to actually provide and accelerate immune reconstitution. More in particular, if we look at single cell level, thanks to Alma Sepica in the lab that produced this data, we see that the heterogeneity, in the heterogeneity of this cell product, we still product, we still have naive cells together with memory cells and Th1 cells. There is also still the presence of FOXP3 T regulatory cells that do not disappear during the 10 days culture. And the TR1 cells are really enriched of, they undergo an expansion because these are the allo-specific TR1 cells, specific for the host antigen. And they undergo an expansion, and indeed they have a T cell restricted repertoire, TCR repertoire. At the same time, they express high level of LAG3 and 49B, and these two markers are used to recognize them just by immunophenotype in culture or also ex vivo. And they also express high level of CTLA4, which is very important for their function, as well as IL-10, which is also essential for their suppressive function. In addition, the peculiarity of these cells is that they become anergic, meaning they become unresponsive to a second challenge with the same alloantigen that they have seen during the priming. And actually the energy is, can be used as a potency assay of these cells. And they are, of course, suppressive versus a primary response towards the same antigens and not towards other antigens. So the hypothesis here that we want to test is whether donor-derived TR10 cells containing alloantigen-specific TR1 cells may induce tolerance to host tissues while preserving immune function. And this is the clinical trial. The clinical trial opened with recruitment of the first patient in 2021. The sponsor is Maria Grazia Roncarolo, and the medical PI is Alice. And yes, it's also called internally BMT367, so you will see this number. The outline of the protocol is a phase 1A, 1B. It's basically a standard haploidentical conditioning for haploidentical transplant starting at day -10. With the presence of the administration of ATG in 3 doses, and then we have the alpha-beta transplant at day 0, and after 1 month, approximately 1 month, in the absence of immunosuppression, and after myeloid engraftment is obtained, we give the cells. The cells, the TR10 cells, are given, and we are testing 3 different doses, which also identify 3 different cohorts of patients, respectively receiving 10 to the 5th per kilo, 3 times 10 to the 5th per kilo, or 1 million per kilo. The primary endpoint of the trial is establishing the recommended phase 2 dose of these TR10 cells, testing the 3 doses that I mentioned, and then safety and by the absence of DLT for 28 days, and importantly, improvement of immunoreconstitution, which with specific in number of patients which reach the threshold of 50 CD4 positive cells by day plus 60 in comparison to our historical control and prospective controls. The secondary endpoint is a cumulative incidence of grade 2-4 or 3-4 acute GVHD, incidence of chronic GVHD at 1 year, and of course leukemia-free survival, relapse, and non-related mortality, although the number that we have, of course, are pretty small numbers. Exploratory endpoint that we care a lot about are the key understanding the pharmacokinetics of the TR10 and TR1 cells, and also understanding the impact of these cells in the immunoreconstitution and in other cell subset. So this is just in one slide, a very, quick summary, and I'm sure Alice can talk more about details. So we have, as I said, 3 different cohorts. Up to now, we have treated 13 patients. Male and female. Age at enrollment has been from a minimum of 1.7 to a maximum of 24 years old. The disease at diagnosis were either AML or ALL, 2 patients with MDS and 1 patient with MPAL. Generally, patients have been in CR2, so and also high-risk patients or this MPAL, which needed 3 induction phase to reach the remission. The first remission were enrolled in the trial. The CD34 positive cells, which were administered, went from 8 million per kilo to a maximum of 35 million per kilo, whereas the CD3 present in the engraftment were always below 10 to the 5th, way below 10 to the 5th per kilo. And the tier 1 cells in the TLO10 cells ranged from 1 to 15% of the given cell dose. Relapse was observed in 2 patients in the first cohort. One was a relatively early relapse and the other one at about 1 year, whereas no relapse were observed in cohort 2 and cohort 3. Acute GVHD post-TLO10 infusion was observed in 2 patients in cohort 1. Both, they were, as you can see, day 33 or day 7, GI or skin only, overall grade 2. No one patient had acute GVHD in the cohort 2, and in the cohort 3, again, 2 GVHD, very mild overall grade 2 and predominantly skin. Chronic GVHD, we have one severe skin and pulmonary GVHD in cohort 1, whereas 1 mild limited skin and 2 mild limited skin in cohort 2 and 3. Patients available for efficacy were basically 3 in each cohort. Only 1 achieved the above 50 CD4 at day 60 in cohort 1. 3 achieved, all 3 patients achieved the efficacy endpoint in cohort 2 and 2 in cohort 3. The follow-up is completed for 1 year in all of them. In cohort 1 and 2 and almost in cohort 3. The correlative study, so we have a lot of correlative study ongoing actually, and I'm going to share only the preliminary reconstitution with you today, and the track and persistence of the tier 1 cells, which are very important. And of course we have multiple time points in which we collect many cells, and we also want to do very apply new technologies, including rhapsodies with transcriptome and expression marker and ATAC-seq to these studies. Here we see as the first question is the pharmacokinetic and tracking the tier 1 cells post-TLO10 infusion. It's a complicated slide, but I hope we can go smoothly through it. You can see each graph is each representing the double positive CD49B LAG3 CD4 memory cells, so the tier 1 cells in the peripheral blood. We have cohort 1, 2, and 3. We have the different timing. The first line is day post TLO10, and the other one is day post HSCT. Basically, the patients receive the cells between day 36 and 42 post transplant. As you can see, there is a peak in the presence, in detection of these tier 1 cells very early on after the infusion. I would say in the first cohort is going to be within the first 2 weeks, and in the second cohort there is a much more increased percentage, up to 20% within the first 2 weeks, and in the third cohort, where we give 1 million per kilo of the Haplo-10, we see the similar increase up to 20% in the periphery, but with a much earlier kinetic of reconstitution. And also after that, there is a sort of normalization, I would say, in most of the patients, with some that remain higher in the peripheral blood. So definitely, I think the kinetic of the presence of these tier 1 cells is pretty clear, with a cohort 3 that has higher and faster detection of these cells early on after the infusion, as well as the cohort 2, and much less in the cohort 1, and definitely superior as with respect to the historical control. This is two different look at this kinetic. Again, we have the all here, and you see the persistence of these cells in the cohort 3 and cohort 2 overall, and also the superiority with respect to the prospective control, which are just patients that we've received the alpha beta depleted transplant without the Haplo-10 in the same time period of the treated ones. And as you can see, there is actually a significance of the difference between the number of tier 1 cells in all the cohort, especially cohort 2 and 3, with respect to prospective controls and normal donor values. Importantly, these cells can be tracked. So if we study the TCR sequencing of the tier 1 in the original cell product, and then we follow all this sequencing in the different at the different time point post transplant in the different patients. So this is the kinetic of 1 year in all the patients in cohort 1, and you can see that by the different numbers, meaning detection of the different sequences that are tier 1 cell sequences of their TCR, and you can see that they are very persistent over the year, and some of them interestingly disappear, some other can reappear at different time points, suggesting that these cells are really recirculating. If we look more in general at the CD4, so that's the endpoint that we want to look at, we can see that the CD4 absolute number is increased, and it is faster reached in cohort 2 especially. So the line which is the red line, but also in cohort 1. So all the different cohorts are actually have significant differences with respect to the general immune reconstitution of the historical control, which is the red line. And of course, the CD4 CD8 ratio goes along with it, with a very high increase, especially in the patients in cohort 3 that receive a higher dose of the cells. This increase, which is dose dependent, is age independent, in the sense that we can, if we divide the cohort of the Haplo-treated patient below and above 17, we can see that the data of the increased CD4 and faster reconstitution of the CD4 is superior, is present in both pediatric and young adult. And we know that these cells are mainly memory cells, both central memory and effector memory cells, but also there is a clear trend with increase of naive cells as well in the Thialo-treated patient, suggesting that possibly our infusion is favoring the naive cells reconstitution as well. If we look at the T regulatory cells, the FOXP3 T regulatory cells, we see actually that these cells are a little bit all over. Certainly they are present and detectable, but at different amount over time, and it is difficult from this data yet to be sure of any possible correlation with other event. I can tell you that these cells this is an immunophenotype where we confirm this data with epigenetic marker of Treg, so they are real Treg, they are not activated cells. However, their presence is not significantly different with respect to that obtained in perspective control. And so therefore, this renders the data that I show you with a significant difference of the detection of TR1 cells in this patient even more important and more trustable. If we look at the viral infection, we can say that up to now, these are of course a very small number. This is a graph showing percentage of viremia per patient cohort and the infection severity. There isn't much difference. I mean, it's difficult to draw a conclusion with this data, but at least we can say that clearly there is no worsening of the infection severity in these patients. And when we go in vitro and we look at the presence of the antigen-specific responses by ELISpot, and here you can see a donor baseline response in blue and patients at 110, 180 in red. You can see in both IL-2 but especially interferon that the responses against the CMV and against the ADV are actually present, suggesting that the Thialo-10 did not impact negatively these responses. So in overall, in conclusion, for now, for this preliminary conclusion on this trial, the Thialo-10 adoptive transfer provides an improved and faster CD4 T cells immunoreconstitution as compared to historical control in both pediatric and young adult. The majority of the CD3 in the first 30 days are gamma delta as expected, and by the way, the Thialo-10 does not change this kinetic of persistence of the gamma delta cells, and then the alpha beta started to increase between day 30 and day 45, and with especially a memory phenotype that increased in all cohort 2 and 3 patients following the Thialo-10 infusion, so in a dose-dependent manner. Naive alpha beta are also slowly reappear, typically beginning around 120 days, and TR1 cells were definitely detected and in a dose-dependent manner shortly after infusion, up to a 20% of the CD4. And Treg are there, not impacted negatively, and actually maybe also having a positive effect on expansion by the Thialo-10. More correlative studies are in progress. I think the data are promising, especially looking in parallel with the clinical outcome that I very briefly mentioned. So, a big village as usual in this, and we at the CDCM and the division, we have a fantastic regulatory team, and also we have a fantastic collaboration and work with the laboratory for cell and gene therapy, so the Stanford GMP facility. of course, the clinicians are fantastic, and I just want to, to mention the research lab because we have really a collaboration between Alice lab, Maria Grazia lab, my lab, and Alma Sepica has been leading. She's an instructor, faculty instructor, and she has been leading the immunomonitoring data. Pauline Chen is our tier 1 expert. And Giulia Barbarito and Linda are from Alice Lab, and they did a great job in the study that I basically showed you. And also thank to Jennifer Corey and the project manager Jennifer Lee. And I'm sure I forgot someone, but thank you very much for your attention. Questions?
Hi, thanks for the talk. I have a question regarding the TCR beta sequencing variation that you showed. So some sequences were like present in a small amount, but then they become pretty high after certain days and then become pretty low. Is there any specific reason for these sequences to be presenting such a high variation? And is it related to any specific cell type or infection?
Yeah, we don't know. We don't know yet. And that's only data from the first cohort. I mean, for now, they instruct us saying that, depending on event, but we don't know which event. Yes, these cells are recirculating. They can be expanded, in different variable ways. So I think it's a very interesting project to follow. Mm-hmm.
Thank you.
Rosa.
Yes.
Just a little bit of an explanation. The product is really interesting, but I haven't quite figured out. Is your product going to, because it has strong kind of T regulatory component to it, it's going to maybe prevent graft versus host disease, maybe affect GVL, but also at the same time you said it has a pro-myeloid therapeutic component. And first, why is that? And can you comment on the risk of a T regulatory enhancement of GVHD protection, either helping or hurting your relapse risk?
Yeah, so the line, of research regarding the tier 1 cells and their ability to be cytotoxic, it's really a huge part of the research of Maria Grazia. These cells have, specific ability to kill myeloid leukemia cells. And so we think that this can be potentially, in case of AML, of course, a good thing. So it's an additional effect, I would say, that it can be specific and driven by the tier 1 cells that is independent from the antigen specificity that these cells are acquiring during the host priming.
So that part sounds good, but you also said at the same time that it has T helper function and decreases graft versus host disease.
Well, because these are other cells that do that, right? So the T-allo10 is a mixed heterogenic population of cells. So the TR1 cells are the only one that become host specific. And therefore they mediate the prevention of the host-specific graft versus host disease, and additionally they potentially acquire this tier 1 AML killing effect. And all the other cells that are there, and they are equal to the parental CD4 population that we put in the culture, they contain naive cells and memory cells, etc. So they are able to fight and to give the immunocompetence and protect towards the other antigens.
Sounds good. It's just a very interesting
I
cell
mean,
product.
potentially they could even, there could have remaining cells that are host specific as well, also in the other cells, but the TR1, the presence of the TR1 should give the suppression. Indeed, they are anergic and they suppress if you put them back with the primary CD4 cells.
Yeah, sounds good. I mean, you're doing enough really good science along with this that you'll know in this heterogeneous population what is helping. So it's a very intriguing thing. It's just an interesting thing that you're giving a product that does so many different things at the same time.
Yeah, thank you.
Hi, Dr. Bacchetta. Okay, thanks for the talk. It was great, exciting. And my question. First, before I ask, could you go back to the tables of the cohorts that I won't make any mistake? There was a table. Yeah, this one. So my question will be the patients available for efficacy and then the CD4 cell counts after 60 days. And what I saw that the cohort 2, there is no AML patient, and all of them achieved CD50 after 60 days. And the cohort 2 achieved, and there were 3 patients, and one of them was a AML patient. And the other hand, the cohort 1 had more AML patients, and then they didn't achieve the CD4 levels as you expected. Do you think is there a relationship with AML and the response of CD4 cells? And I want to hear your thoughts about that.
Yeah, I don't think so. No. I don't think we are able to make that correlation. No.
Okay. Thank you.
Okay. Okay. Thank you.
This is the moment where everybody who has not eaten lunch, which may be the minority, should go out and get lunch. And then I ask you to come back because Raul, who is a former fellow at our institution and now in Las Vegas, will have a little special session on biomarkers for GVHD. And then we'll continue with the session 7 on manufacturing at 1:30. And then we're back on schedule. So lunch, and then please come back.